We know we have workable slides, and I know I've got a great speaker because Dr. Bart is on the faculty here at the medical center where I work in chilly Minneapolis. Welcome everybody to the ACMT Grand Rounds webinar series for the month of February. As you know, we do this every other month on the second Tuesday at this hour. And we're always excited to hear from you if you have local friends or have made other contacts at areas where people practice, research, and otherwise work on the edges of toxicology and inform the work that we do. This time I have the pleasure of introducing Dr. Gavin Bart, who is a marvelously overeducated and highly productive MD PhD here on the faculty at Hennepin County. He heads the Addiction Medicine Division and has training in medicine as well as a fair bit of background in research, including some of it in neuroscience to support what he's going to talk to us about, at a number of leadership positions, and has had a chance to work in a variety of different settings, thinking about how to come at the problem of addiction and what it brings to our acute hospitals, and how to prevent there from being problems that become bigger than patients would have originally liked them to be when they were first prescribed some of the junk that they get hooked on. We're going to talk specifically about a drug that we prescribe to try to beat back some of the difficulties in opioid addiction today. Everyone is aware of the fact that there is a lot of discussion about drugs that can affect cardiac repolarization, many of them psychiatric drugs, many of them the things that our patients take in purposeful overdose. But we have this additional wrinkle that methadone can be a life-saving treatment for some people with addiction, but also at least has the ability to bind with a potassium rectifier and create some distress on our part. And Dr. Bart has been interested in that distress and how serious it is and what the data is or is not to support how much this question concerns us. So without talking about his talk itself, I'm just going to turn it over to him. And just remind you folks, if you have any questions or comments during the middle of things, if it's really urgent, I'll be happy to break in to make sure we get a clarification. Feel free to send me a note in the background. You can't even raise your hand too, and I can try to chat with you offline. Otherwise, we'll do most of our Q&A at the end with the standard hand-raising process. So I'll turn it over. Dr. Bart, it's yours.
Thank you, Dr. Seamus. And thank you for inviting me, everyone, from American College of Medical Toxicology. I have to throw in the disclaimer, I am not a toxicologist. And since I'm going to be talking about something cardiac, I have to say I'm not a cardiologist either. But I am an internist, and I focus on addiction medicine and quite specifically opioid addiction and even more specifically its treatment with methadone. And so this has been a topic that's been around for a while in terms of the cardiac effects of methadone for a number of years. And I'm going to just spend today kind of dissecting some of the history of that and talk about some of the recommendations that are out there and maybe try to dissect those a little bit. But I have here on the face slide, Pyrrha Ellis, who, at least in the world of philosophy, is noted to be the first skeptic. So I think I already sort of disclosed my hand when I'm going to talk about the cardiac risk and methadone here, because I think there is a need for a healthy dose of skepticism. As a primary disclosure, I have no financial conflicts of interest. Some of the work you're going to hear today was supported through a Career Development Award from the National Institute on Drug Abuse. And the basic learning objectives would be learn a little bit about the various guidelines and recommendations out there regarding cardiac risk and methadone, to understand the relationship between methadone and the QTC interval, and then to tie those two things together to figure out if there are ways to reduce cardiac risk, or even if that's necessary to at least improve patient safety. I'm going to start with just a case to get things going. This is a case seen in our hospital here at Hedman County Medical Center. 65-year-old gentleman, African-American male, with a witness arrest. So he collapsed while waiting in line in the morning at a methadone clinic, not our clinic, but at a local methadone clinic. EMS arrived on the scene. He was in VFib and then into pulse electrical activity. Had a total of 34 minutes of CPR in the field and during transport to our emergency department. In the emergency department here, he was also in VFib and cardioverted into sinus rhythms, but held that for only 10 seconds. And after an additional 31 minutes of CPR, he was pronounced dead within the emergency department with no apparent cause. So this is a pretty dramatic presentation that raises a lot of questions. And it would fit sort of the ICD-10 definition of a sudden cardiac death, which would be a death from any cardiac cause. Generally, it's out of the hospital or in an emergency department or dead on arrival. And for the most part of this definition is that the death occurs within an hour of symptom onset. Perhaps during the discussion, we can talk about why that's important, the timing, especially in people who are on opioids. So as an overview of just out-of-hospital cardiac arrests, in a study of over 20,000 out-of-hospital arrests, not everyone starts with, a VFib, VTAC arrest. In the field, when people are discovered, unfortunately, the majority don't have any rhythm analysis performed, but you can see there's a distribution between asystole and VFib, VTAC, and PEA. And about 60%, there is an attempt to resuscitate in the field. And with resuscitation, initial rhythm in those people, again, it's most commonly asystole or PEA, followed by VFib, VTAC. And as we know, the overall survival rate of an out-of-hospital cardiac arrest is exceedingly low and below 5%. So this gentleman certainly fits into that category. And when there's an out-of-hospital arrest, we have to think of the, you are the poison experts. Why did he die? And the 5 H's, the 5 T's might explain this. Could it be a volume issue, hypoxia, electrolytes? Certainly overdose plays a big role, or other toxidromes, pneumothorax, thromboses, whether it's cardiac or pulmonary. For this gentleman, I don't have a happy ending to it in the sense where there was an autopsy and we know what happened. Ultimately, we don't know what happened to him. But it raises the question about methadone and QT prolongation. I mean, my goodness, here's a person who had an arrest and died while waiting in line to get his daily dose of methadone. So let me turn now to that issue of methadone and the QTC. Certainly the corrected QT interval has been linked to torsade de pointe. And that interval has a variety of measurements, although quite often these measurements, with so many automated readers that have their own algorithms, no one, with the computerized algorithms, it's not so commonly just a Bazet or a Federica formula. They're using lots of algorithms within the automated ECG machines, and each algorithm has maybe its benefit and deficit. But in general, a normal corrected QT interval is less than 450 milliseconds for men and less than 460 milliseconds for women, and QTCs greater than 500 milliseconds are considered high risk for development of torsade de pointe. Now, QT prolongation generally reflects sympathetic imbalance, either through increased sympathetic tone or decreased parasympathetic tone, or some alteration in the balance between the two, and that prolongation and that imbalance can sort of lower the threshold at which VFib can occur. And then if you add into it a situation of ischemia, it can certainly increase that risk further for ventricular arrhythmia. There's also a series of genetically mediated channelopathies with a variety of mutations in cardiomyocyte, calcium channels, and other electrolyte channels that can increase QT intervals and predispose to sudden cardiac death. That's estimated in the general population. These channelopathies are present in about 1 out of 5,000 individuals. So when it comes to methadone and QTC interval and torsade de pointe, really the clock starts in 2002. Now, as a background, methadone for the treatment of opioid use disorders got its origin in 1964 when it was first used for maintenance treatment. And so between 1964 and 2002, basically the literature is silent on this. But in 2002, the Annals of Internal Medicine, Maury Kranz out of Colorado, presented a case series of 17 patients who had torsade de pointe, all of whom were on methadone, with quite elevated, quite prolonged QTCs of 615 milliseconds was the mean, and these people were on whopping doses of methadone. The mean dose was 397 milligrams. Now, these 17 patients had a number of other things going on. 8 of them had low levels of electrolytes, in particular potassium or magnesium. 3 had some form of structural heart disease, generally valvular problems. There was often polypharmacy, including medications, whether antibiotics or antipsychotics or HIV medications, known to also prolong the QT interval. And 10 also had bradycardia, which is certainly something induced by all opioids, not just methadone, but can also affect the risk for development of torsade de pointe. So there were a number of factors going on in this case series. Now, I think for poison center people, I want to create sort of the analogy of a sentinel event, you know, that where then we see an increase in events thereafter. So this is just FDA date and sort of the number of cases reported between methadone and QT interval prolongation, and there's this peak, initial peak 2002 with the publication of the Kranz case series of 17 patients, and once that sentinel event of a publication occurs, you can see the number of cases that are reported also begin to increase. It's almost like you know, it's sort of like a Hawthorne effect. Once it's reported, everyone's looking for it, and the reports begin to snowball. And with that, a series of guidelines ended up being developed. And I'm sorry the animation on this slide did not come through, but we have the American Pain Society and the College on Problems of Drug Dependence publishing guidelines. We have the Substance Abuse and Mental Health Services Administration publishing guidelines. We have guidance from the American College of Medical Toxicology, of which this text capture comes from, about clinicians should obtain a baseline ECG before methadone treatment in patients with risk factors for QT prolongation or other medications, et cetera, and should provide a follow-up ECG 30 days after starting therapy. And these are sort of the common themes between the various guidelines that got published. Ultimately, a Cochrane collaboration meta-analysis was also published that did not conclude the evidence was sufficient to support these recommendations, but nevertheless, a lot of these recommendations were put out there. And that's really what I want to turn to for the rest of this presentation, is sort of the literature upon which these recommendations for QT monitoring and EKG risk stratification were created, to see if I can help clarify that and maybe create some healthy skepticism. So, pulling from the Substance Abuse and Mental Health Services Administration recommendations, their expert panel had the preamble that said this was a means to enhance patient safety, and to do such, every patient starting methadone needed a clinical assessment, including risk for sudden cardiac death, and that there should be ECG monitoring for those at risk with risk stratification using the QTC interval, and that there should be awareness of drug-drug interactions. Well, let's see some of the literature that this is all based on. So, there were a couple of cellular assays. So these are patch clamp studies looking at the human ether, a go-go channel, an ion channel, transfected into a cellular membrane, and then looking at ion flux at various concentrations of methadone. So these experiments looked at concentrations of methadone between 1 and 10 micromolar, and found that there could be interruption of ion flux at concentrations approaching 9.8 micromolar, thereby indicating that methadone could affect ion flux on cardiomyocytes, and therefore predisposed to QT interval prolongation. Now, if we do a translation of what these 9.8 micromolars would mean, it ends up being roughly a 3,300 nanogram per milliliter in a human. But because these are patch clamp studies done in a Petri dish, it doesn't have the same protein binding as we see in humans. So if anything, it may be even a tenfold off of what they report here. And so most humans that I take care of walking around in my methadone program have methadone plasma levels between 300 and 900 nanograms per milliliter. And again, that is total methadone. That's not unbound methadone. So it's about 90% protein bound. So the unbound is going to be between 30 and 90 nanograms per milliliter. So what they're seeing in terms of IC50s is really occurring at concentrations that far exceed what your typical human being would encounter during therapeutic methadone dosing. So we have to take these patch clamp studies with a little bit of grain of salt. Well, we don't see a whole lot of intravenous methadone in hospital settings. Chlorobutanol is part of the intravenous formulation. Now, this is different than diverted methadone, oral methadone being injected. This is the actual FDA, preparation. Chlorobutanol can also potentiate, so depending on how the experiment is conducted, whether it contains chlorobutanol may be a contributing factor to ion flux across channels and may contribute to some of the case series of patients experiencing torsades in hospital settings upon receiving intravenous doses of methadone. The other thing is methadone, as we administer it clinically in the United States, is a racemic mixture between the R and the S methadone, with the R methadone having the opioid agonist activity, and the R and S methadone being NMDA antagonists, but the S methadone does not have the opioid effect. And it seems that, at least in the patch clamp studies, the effect on ion flux is really S methadone specific, so to the non-opioid component of methadone. If we move away from just the basic science cellular studies, there have been some forensic series. A series in Portland followed 72 decedents who had been taking methadone, 43 of whom died of drug overdose, and 111 decedents who weren't on methadone. And a number of these decedents had autopsies, and 77% of those who were autopsied who were on methadone at time of death had no type of cardiac findings on autopsy, whereas only 40% of those who weren't on methadone at time of death and were autopsied had no cardiac findings. So it was felt that with fewer cardiac findings in the methadone patients than the non-methadone patients, that might mean that methadone could potentially be contributing to these deaths. Again, it's not disclosing what the cause of death is in these individuals. These are people who are dead. They happen to be on methadone. There's not a clear indication of cause of death in all of these people. Again, 43 were rated as drug overdose. So this forensic series was used to support this idea that methadone may predispose to some form of sudden unexplained death, and that these people with sudden unexplained death were more likely to have no cardiac findings than other people who mysteriously died and weren't on methadone. Now, it's interesting to note that the author of the forensic series has reported other literature on sudden cardiac death and notes that forensic series tend to overestimate the occurrence of sudden cardiac death between 200 and 300%, because this is certainly the inherent methodologic flaws of doing a forensic series. But if we go more into living human beings, so instead of cellular patch clamp studies or forensic studies, just looking at cross-sectional evaluation of people on methadone, a study out of Denmark found that in more than 400 people on methadone maintenance for an opioid use disorder, that about a third of them had a QTc of greater than 440 milliseconds, and 2% actually exceeded that 500 millisecond threshold. And at least based on self-report, about 20% of the population self-reported syncope. Hard to know what that means, but at least it's a self-report of syncope. Could that be sudden dysrhythmia leading to loss of consciousness? Who knows? Another study out of Scandinavia, 200 Norwegians on methadone, about 3.5% had a QTc of greater than 500 milliseconds, and 1% of them had a confirmed long QT syndrome, heterozygote genotype. So again, not that common to have a channelopathy, but certainly channelopathies do occur in people who are also on methadone. Another cross-sectional study of 180 patients on stable dose methadone and who were not on other QT prolonging medications. About 9% had QT intervals greater than 440 milliseconds, and none in this series had a QT interval of greater than 500 milliseconds. Now, there are only a couple of prospective studies where we're actually able to get some pre-post methadone QT interval data. One out of New York, following 167 methadone patients who at baseline upon admission to the methadone clinic had an ECG and then follow-up ECGs at 6 and 12 months after starting methadone. And the mean baseline QT interval was 418 milliseconds, and 6 months later it was 431 milliseconds, and that was a statistically significant increase in the QT interval, although it was from a clinically normal QT interval to a clinically normal QT interval. And overall, they found that about 2% of the population, as seen in the cross-sectional studies, also had QT intervals of greater than 500 milliseconds. A subset of these patients that were evaluated had some methadone peak and trough plasma levels measured, and there seemed to be no relationship between methadone plasma levels and QT interval. The other prospective study is out of a combination of clinics in Israel and Las Vegas, evaluated ECG data from baseline upon admission to the methadone program, and then after patients had been on a stable dose of methadone for at least 3 months. So it was not at a set 6 and 12-month interval, but after whatever clinical stabilization period had occurred for at least 3 months without dose change. And as with the New York study, the mean baseline QT interval was normal, 427 milliseconds, and once stabilized on methadone for at least 3 months, it rose to 437, a statistically significant increase in the QT interval, but both within the clinically normal range. Another small prospective study comparing methadone to levo-alpha-acetylmethadol, which is no longer available on the market, versus buprenorphine. You could see that through time over this 16-week study, both levo-acetylmethadol and methadone participants have increases in their QT interval, whereas buprenorphine does not. And about 10% of the methadone patients had a QT interval greater than 500 milliseconds over the course of the 16-week period, and none on buprenorphine. So that about wraps up the prospective data on methadone and the QT interval. As I mentioned earlier, the patch clamp studies found that increased ion flux was related to S-methadone, but not R-methadone. And in the United States, we give the racemic mixture, but in parts of Europe and Germany in particular, they have the ability to give R-methadone only. And so an interesting study took a small group of people who were on methadone, the racemic mixture, got QT intervals, switched them to the R-methadone only, thereby getting rid of the S enantiomer that, at least in the patch clamp studies, has been associated with QT, or at least with increased ion flux, for 7 days, and then, or for 14 days, and then switched them back to the racemic mixture. And you could see that throughout, the QT intervals means are normal, and that the switch from the racemic mixture to the R-methadone did not really result in a significant decrease at the end of 14 days, and that switching back from the R only to the RS racemic did not lead to a significant increase in QT interval that was of any clinical significance. These are very small impacts on the QT interval. So I think thus far in this presentation, I hope I've convinced you that the data, whether it's patch clamp, cross-sectional, or prospective series, that there is a very strong foundation to implicate methadone in QT prolongation. We saw in the prospective studies that methadone led from a normal QT interval to a longer yet still normal QT interval. Absolutely, there is no question that methadone will increase the QT interval. So the next question is, so what? Does it really matter? Is it of clinical significance? Well, let's look in general at the risk of long QT syndrome. So these are people with the genetically mediated disorder. What is the outcome of having a prolonged QT interval? And if people have a QT interval less than 500 milliseconds, their annualized or 5-year risk of sudden cardiac death is about 0.5%. But as that QT interval crosses the 500 millisecond threshold, it goes up to 3 and even 14%. So there is a very serious risk, at least in people with a genetically mediated channelopathy, that QT prolongation can result in sudden cardiac death, especially when that interval exceeds 500 milliseconds. We have less data specific to people who don't have this genetically mediated syndrome. In general, we know that sudden cardiac death, only about 25% begin with the ventricular tachyarrhythmia, which is what this prolonged QT interval can lead up to. And that ventricular tachyarrhythmia, it can occur in a variety of settings. Obviously cardiac disease and electrolyte abnormalities, the channelopathies, metabolic disorders, and certainly toxidromes. We know that the QT interval greater than 440 milliseconds, at least in the general population, study of over 3,000 individuals, that there is a relationship, weak though it is, between having a QT interval greater than 440 milliseconds and all-cause mortality, and that cardiac-specific mortality risk is 3 times higher in people who have a QT interval greater than 440 milliseconds. But that's a general population. If you take that general population and you separate it out into the healthy individuals only, you weed out those who have pre-existing cardiac disease, you find that the relationship between a QT interval greater than 440 milliseconds and all-cause mortality disappears, and that there's no relationship between fatal or non-fatal cardiac events when you look at the QT interval greater than 440 in people who don't have underlying cardiac disease. If we look at Framingham data, the prevalence of a QT interval greater than 440 milliseconds in the Framingham population was 5.4%. Women have longer QT intervals than men, so it was 7% in women, 2% in men, and through time, following people in the Framingham study, there was no relationship between the QT interval and total mortality, the occurrence of sudden cardiac death, and coronary artery disease death. And in a large meta-analysis of 7 prospective studies that total more than 36,000 patients, 8.7% of these 36,000 people had a QT interval greater than 440 milliseconds, and during the periods of follow-up, which in these articles range from 2 years to 30 years, the risk of death was only increased in those who also had prior cardiovascular disease. And that sudden cardiac death relative risk in that population ranged between 1- and 2-fold. So again, there's very little correlation between QT interval prolongation and those without underlying cardiovascular disease. We look at sudden cardiac death in methadone populations, so another Scandinavian study. This is really kind of looking at post-mortem data of people, everyone's on methadone, they've died. Is there post-mortem information? Is there not post-mortem information? Do we have potential causes of death? Was it overdose, traumatic, unknown, et cetera? There was an estimate based on the number of patients, over 2,000 patients with almost 6,500 patient years on methadone, an estimated mortality rate due to sudden cardiac death or QTC prolongation of about 0.6 events per 1,000. We look at the general U.S. population. So sudden cardiac death in the general U.S. population, it's about 1.75 per 1,000. And I live in Minnesota. The case that I started you off with, of the gentleman dying in the methadone clinic, occurred in Minnesota. So the sudden cardiac death rates in Minnesota are about 1.34 per 1,000 in the general adult population. So what we did here at Hennepin County Medical Center is we looked at our methadone population and did a retrospective cohort analysis of 1,100 admissions to our methadone program, which consisted of 778 unique individuals. And we scanned our electronic health record for any evidence of an ECG in this population. We found that 749 of our individuals had evidence of an EKG within our health record. Now, some of these individuals had their ECGs performed at a time when they weren't taking methadone. Some of these individuals had ECGs performed at a time when they were on methadone. And some of these individuals had ECGs performed at times both on methadone and off of methadone. So it created a very nice opportunity to have a control group of people who had all of the predisposing factors of being on methadone in terms of the background issues of addiction and other problems, and we could do even intra-individual controls, because we had a number of people with EKGs from when they were on methadone and not on methadone. And we followed their QT interval from the EKG and looked at a couple of differences in them. We looked at racial differences, the setting of the ECG, because some people, end up in the emergency department and have that ECG. Some may only have it in an outpatient or an inpatient setting, and that might make a difference in what their QT interval was. And we looked also at the dose of methadone, at least in those people who had an ECG while they were taking methadone. And you can see from our population, people who had an ECG while they were taking methadone were generally older than those who had an ECG while they weren't taking methadone, and that there were some differences in race and ethnicity. No differences really in the setting of where the ECG was obtained in terms of whether a person was taking methadone at the time of the ECG or not on methadone. And the people who had an ECG while taking methadone, mean QT interval was 436 milliseconds versus 423 milliseconds for those who had an ECG while they were not on methadone. And that's a statistically significant difference. Then the mean methadone dose for those who were on methadone at the time of the ECG was 77 milligrams, ranging from 1 milligram to 285 milligrams. In the subset of individuals who had ECGs both while taking and not taking methadone, so 211 people where we had 2 ECGs from each person, we did comparisons of their on methadone versus off methadone ECG, and again found that there was a statistically significant difference in the QT interval in these individuals while they were taking methadone compared to when they weren't taking methadone. But nevertheless, these QT intervals averaged within the normal clinical range. We did a dose correlation between methadone and the QT interval. And while we did find a statistically significant effect of dose when we did age adjustment to the QT interval, the clinical relevance of this is very questionable. The R-squared was 0.05, so the majority of the variability is explained by other factors than the methadone dose. And if we look at this regression, really what it translates into is basically every 1 milligram increase in methadone dose would equal a 0.2 millisecond increase in the QT interval. So it's very questionably dose-related, at least in terms of clinical significance, despite there being some statistical significance. Again, we had a number of people who had a QT interval longer than 500 milliseconds. Our percentage didn't really vary from the extant literature, and people who had ECGs while taking methadone were more likely to have a QT interval greater than 500 than those who weren't taking methadone at the time of it. Although interestingly, 4 out of 10 people with a QT interval greater than 500 milliseconds while taking methadone continued to have a QT interval greater than 500 milliseconds when not taking methadone. So methadone couldn't be the sole cause of that QT prolongation. But what we did, importantly, I think, is try to answer the so what question. We know methadone increases the QT interval, but how does it relate to clinically important events? So we used the electronic health record and we looked at all diagnostic codes in the ICD-9 family of 426 and 427. So that would be all conduction disorders and all cardiac dysrhythmias for all 749 patients that we included. And we then identified that of all of these 749 patients, there were a total of 44 ICD 426 or 427 diagnoses covering over 7,000 patient years. And you can see the list of the various diagnoses. Not all of these diagnoses can predispose someone to sudden cardiac death. You know, a PAC is not going to, or a PVC is not going to contribute. So we whittled it down to 18 diagnoses that could be plausibly associated with sudden cardiac death. We were very conservative in this. In fact, we even included bradycardia as a diagnosis that could plausibly result in sudden cardiac death. And then we evaluated, because some patients were on methadone, some weren't on methadone, we looked at QT intervals, we evaluated sort of the correlates of having these diagnostic events. So what we found is that in over 7,000 person years, there were 44 events leading to a rate of 6.3 per 1,000 patient years, but of the 18 diagnoses that could be plausibly related to methadone, plausibly linked to sudden cardiac death, we were at a 2.5 per 1,000 patient years. Now, the actual sudden cardiac death, because we had 3 patients who had sudden cardiac death, so our actual sudden cardiac death rate was 0.42 per 1,000. As I mentioned before, our state-adjusted sudden cardiac death rate is 1.34 per 1,000. So our actual sudden cardiac death was 3 times lower than the state-adjusted sudden cardiac death rate. But if we include any of the predisposing plausible diagnoses, we were not quite twice as high as the actual sudden cardiac death rate within the state of Minnesota. But again, not everyone had an event while they were taking methadone. So when we looked at the relationship to methadone, we found that the hazards ratio of having an event that could plausibly lead to sudden cardiac death was 3.32 if a participant was a man and had a QT interval greater than 450 milliseconds, or a woman and had a QT interval greater than 470 milliseconds, but there was absolutely no relationship to having an event and whether the person was taking methadone or not. So the QT interval was a predictor, or at least correlated to the event, but methadone itself did not relate to the increased risk for having one of these diagnostic events that could predispose to sudden cardiac death. Now, there are obviously limitations of this type of study. This is a retrospective chart review. It's a restricted sample size. It's only 749 patients. It's a single site record review. Now, we are the major trauma center. We, the majority of patients in our methadone clinic get their medical care here, and if they have an event outside of the hospital, they're going to end up in this hospital, although maybe if they were pronounced in the field, they wouldn't end up here. So, could they have ended up in another hospital? Potentially, and we might have missed an event. And we don't have a comprehensive death registry information from the overall population to know how many of the total population we evaluated died, whether or not it could have been cardiac related or not. But this is at least the first paper I'm aware of, despite its limitations of being a retrospective chart review, that tries to follow up this known relationship between methadone and QT interval prolongation with the occurrence of actual events, trying to answer that so what question. Does it clinically matter that methadone increases the QT interval? And at least from this literature, or at least this one study, it does not appear that methadone is really playing a factor in a diagnostic event that could predispose someone to sudden cardiac death. So to conclude with, corrected QT interval greater than 440 milliseconds is associated with death in patients who have known cardiovascular disease. That methadone patients will have events, but the relationship to being on methadone is unclear, and that there is a very weak relationship between the dose of methadone someone is on and the QT interval, at least at standard clinical ranges of doses. We have no evidence that we can do risk stratification or that screening people for a QT interval at admission could help us intervene in any way that would lower their risk for sudden cardiac death. And therefore, I would conclude that patient safety really wouldn't be improved by screening patients upon entry into a methadone clinic with an ECG. And in fact, a statement from the American Heart Association, the American College of Cardiology, and the Heart Rhythm Society probably say it best, is that the present data do not support the use of QT interval for risk stratification for sudden cardiac death in patients without long QT syndrome. Now, this is really specific to people with known heart disease and isn't being guided towards methadone patients. But again, I think that there's very little indication that we can risk stratify or prevent the occurrence of events by engaging in some form of screening of all methadone patients. This study, certainly a lot of people played a role in it, and I want to call out one of our pharmacists here at Hennepin County Medical Center who, while he was getting his PharmD, compiled most of the data, so Zachary Wyman, and our own Dr. Joanne Lays, who is part of the American College of Medical Toxicology, who gathered a variety of the data that ultimately we didn't use, looking at some of the lab values in terms of calcium and magnesium in a subset of the population that we studied. But we're very pleased to have her on board now as faculty. And hopefully there's time. It looks like we've got about 10 minutes for questions. So JJ, I don't know, do you want to moderate?
I'd be happy to. Dr. Barr, thank you so much for your talk. Very useful to have the review of what really is out there for published literature and useful data in addition to the study that you conducted here locally. I'll remind folks, please just do raise your hand. You'll come in muted, but I'll unmute you and get you talking directly to Dr. Bart. Since I don't see any hands right away, I'll start out with a brief question for you, and then hopefully it'll launch us into more discussion generally. Because it appears that there really is no role for screening electrocardiography in patients who would start methadone, the current recommendation then in your eyes would be simply to be querying for a personal history of syncopal events or other potential markers of arrhythmia, and perhaps a family history of sudden cardiac death as a starting point. And if that were to be negative, there wouldn't be a role for electrocardiography in methadone patients, but perhaps if those screening questions were positive, it may lead you down the road to chasing a genetic anomaly in a long QT patient before you started methadone. Would that be the way you'd approach it, or something slightly different?
Yeah, I mean, I think that's a really good question. So, I mean, a number of the guidelines outright recommend getting an ECG. The SAMHSA report didn't go that far. They at least recommend some form of risk stratification. And our methadone program here is a joint commissioned one. And the joint commission, of course, we're seeing the effects of what happens when the joint commission recommends things that aren't necessarily evidence-based, at least when it comes to pain as the fifth vital sign. At least when it comes to methadone, the joint commission does require some form of risk stratification. It doesn't specify it has to be screening ECG. So what we do in our clinic, probably not because I think it's clinically indicated, but really to comply with Joint Commission, is ask the family history of sudden cardiac death, personal history of dysrhythmia, syncope and underlying heart disease, and then based on whether a patient endorses those symptoms, we will consider what needs to be done next. Very rarely will we escalate it to an outright screening ECG, depending on what the patient says. You know, unless there's a clear sort of, you know, we've had a couple of instances where, yeah, I had a brother, he was 25 and he just collapsed and died and no one knows why, and it wasn't an overdose. You know, where we may do a screening ECG. I can't think of any instance where it's actually made a difference in terms of either unveiling a heretofore undiagnosed channelopathy or prevented us from recommending someone initiate methadone or continue it. I think the bigger challenge we have is not so much what to do with someone who starts methadone, it's what to do after a cardiac event. So, you know, a long-term smoker, diabetes, you know, in their 50s, 60s, you know, hasn't, you know, a very clear thrombotic, you know, myocardial infarction. They have a STEMI. And post, you know, now they're in the hospital, they've been revascularized, and now their QT interval's starting to creep up, yet they're on methadone. And then we deliberate, we ride this out because the QT interval is going to be expected, or it wouldn't be abnormal for it after an infarction to increase, and then it kind of goes back down after revascularization. Do we just ride it out, or do we come up with an alternative plan? And that, I don't have a clear-cut answer to. We kind of do that on a case-by-case basis.
Thanks very much. We have a question or a comment here from Tom Kurt. Go ahead, Tom.
I have really two questions. Is there any kind of a drug interaction with benzos or muscle relaxants, which are commonly prescribed with methadone, in further increasing the prolongation of the QTC or increasing death risk?
Thank you. Let me separate that out. So I am not aware of literature linking benzodiazepines to QT prolongation. One of the studies out of Israel tracking people in terms of QT interval tried to separate methadone patients who were using benzos and those who weren't using benzos to see if there was a difference in QT interval, and I think they found a slight difference in QT interval. There's certainly a synergistic effect between opioids and benzodiazepines in terms of the chances for respiratory suppression and death from hypoxia and overdose. And of course, one of the things I worry about, and I mentioned this at the beginning, where there's a clear definition of sudden cardiac death where, at least based on ICD, it's really from symptom onset, if there are symptoms, to time of death is really generally defined as a 1-hour time span. And overdose deaths, although even that's changing now with fentanyl and carfentanil out there, overdose deaths tend to evolve through time over what can be a few hours of, ongoing respiratory suppression and hypoxia leading to anoxia and death. And so I do wonder a little bit about the potential to bias the diagnosis of sudden cardiac death when, in fact, there was probably overdose situations that may have, those overdoses may have been exacerbated through co-ingestion of methadone or other opioids and benzodiazepines, but unfortunately the examiner calls it as a sudden cardiac death rather than as an overdose. So I think that ends up being a confounding issue and why forensic series are so challenging.
Good morning, Arizona. You have a comment or a question for Dr. Bart?
Yeah. Dr. Bart, how do you go about then risk stratifying patients who are on methadone who are also on other QT prolonging drugs such as psychotic medication or other medications that might prolong the QT?
Yeah, I think that is a really good question. I don't have a great way to say we can risk stratify them. In some of the other studies that have been done, whether it's people who are using cocaine, which certainly is related to dysrhythmia and QT prolongation, and whether it might be other medications, there does seem to be some indication that minimizing or reducing those other QT prolonging medications can at least decrease the QT interval. Whether it decreases the risk of event, we don't know. So sometimes getting rid of the cocaine without changing the methadone can bring the QT interval back down. And so when it comes to polypharmacy issues, my general recommendation is in a situation where there already is a prolonged QT interval and the patient is on methadone, to find, wherever possible, alternative medications that do not prolong the QT interval, if that's possible. And obviously, sometimes we're in a bind and you can't avoid it. And I don't think there's any clear data to say what to do if, what do you do with that person who's at 470 milliseconds and they're on methadone and they're on, any number of medications that can prolong the QT interval. There does seem to be some link between a QT interval that long and having an event. But we also know stopping the methadone or switching them to another medication can create risk for relapse and overdose. And it doesn't always go smoothly to do that transition to, say, buprenorphine. So I don't think it can be reduced into an algorithm or a formula for risk stratification, but it has to be managed by reducing the number of insults possible. So I would first go for limiting other QT prolonging medications when possible, and if not possible, watch carefully and consider, again, maybe something like buprenorphine.
One more question from Suzanne Doyon.
Hi, hello, can you hear me?
Yeah.
Okay, great. So I just wanted to perhaps toot my own horn, but look into this problem of polypharmacy in these patients. I did a retrospective review of medical examiner deaths that involved methadone, and all of them had post-mortem serum concentrations that were what we would, under 1 or under your sort of threshold, whatever, for it not to be called a methadone overdose death. Anyways, and looked at what other drugs were detected. The median were 3 QT prolonging drugs, with one patient having 9 QT prolonging drugs in the postmortem toxicology. So I think this drug interaction and the compounded effect of multiple QT prolonging drugs being co-prescribed to a methadone patient is a real problem, and I think that needs to be really looked at in much more depth. Citalopram, promethazine, there are many, many, many QT prolonging drugs, antipsychotics that we're finding postmortem in these patients. That's it.
Okay, yeah, thank you. And indeed, we do, methadone itself may not be enough, but, is it a 2-hit, 3-hit, 4-hit hypothesis? Quite possibly.
Thanks very much, Dr. Bart, and for all those comments, too. Although it wasn't the focus, we often think a lot about what goes on in the acute hospital setting to taking care of patients who might start on methadone or are already on them, and then there are a long list of medicines, too. At least we know that the hospital itself is one of the safest places to have a potential event and have a lot of variables controlled for that could reduce risk. And so it's useful to know that even the outpatient data are not that strong for making methadone itself something that we have to worry about alone. On the other hand, because our patients are so complicated with so many comorbid medical problems, so many long lists of drugs and other potential interactions, at least in the hospital we can control some of these things, but when they go off into the world adding all sorts of interesting chemicals, then the mix does get more complicated. And of course our worry then gets greater regardless of the data or lack thereof. So a tough issue, but certainly very useful to have some real data to go on and some sharp thoughts that are really focused on what is out there rather than the myth and the worry alone driving our practice. So I'm really grateful to be part of the same institution here where we get to share these kinds of stories, and I'm very happy to have been able to share your expertise with the college by inviting you to speak. Thanks so much for your time, and thank everyone else for your time in attending too. I know we're a couple of minutes over, so I'll just remind you, if you have any other folks to let us know about who might want to participate in this venue, please give us a shout on the Education Committee or to me or Steve Walsh. And we'll see you again, same time, same station in April. Thanks again, Dr. Bart.
Thank you.
Right. Have a great day, everybody. Happy Valentine's Day. Be safe out there. Bye-bye. Gavin, that was great. Thank you so much.